Welcome back to episode 2 of Outcomes by Design. With me today is Joe Nadglowski, the CEO of the Obesity Action Coalition, a nonprofit organization founded in 2005 to empower those who are affected by obesity through education, advocacy, and support. He has 20 plus years experience in patient advocacy and education, fueled by his passion to eliminate weight bias and expand access to obesity treatments. Joe, welcome to the podcast.
Thanks for having me. I'm excited to be here.
Oh, thank you. We're excited to have you. And for listeners who aren't familiar with the Obesity Action Coalition, can you describe in more detail what the organization does and who it's fighting for?
Yeah, so OEC is the patient advocacy organization in the obesity space. And we were founded now just over 20 years ago after a legislator stood up at a meeting on obesity and said, I'm asked every day to do something about the obesity epidemic, but it's always by a healthcare professional or by a public health official. I've actually never had someone with obesity walk into my office and ask me for help. He then went even further, and this was 20 years ago, right? So, sort of the heyday or the start of bariatric surgery. And he said, I could ask my state legislature to pass a law to ban bariatric surgery, and not a single person who needed surgery would march on my front steps. Where are the patient advocates? And so from that moment, there were a group of 3 people in that room who heard that story, and they found an angel donor, and they recruited me away from the American Association of Kidney Patients to actually start OAC all those years ago. And that's what we've done ever since then, is actually represent the voice of people living with obesity. And you see that in our advocacy work as we educate policymakers, but you also see it in our education and support work to try to support people on their journeys. And we're really proud of the education and support work we do as well. Probably best known for our advocacy, but the support and education work where we try to give evidence-based information to people living with obesity to make the best choices for them, we are super proud of.
And that's such an important thing that, with all the information that's out there on social media, there aren't great resources for patients to go to that you can trust reliably, that are evidence-based, and also, given through the perspective of people who are living with the disease as well. It's very different. And I think what you're doing is greatly needed. And how has the organization evolved over the past, what is it, 20 years now?
Yep,
21?
20 years. Yeah, so again, I think in the early days, it was interesting times because we were trying to create a patient organization in a world where there weren't very many treatment options, nor was there a lot of trust in people because people had been so stigmatized and blamed and shamed over time. And so, I will admit the first couple years at OEC was a little lonely as we tried to build that trust and nurture the community to do that until now, where we have over 100,000 members, right? And people who have raised their hand, people like me who live with obesity and say, I want to be a member of an obesity organization to get the support I need. And we'll find people, all along their journey, right? So you have someone like me who's been in a dozen behavioral programs. I'm only seventh medicine now to treat my obesity. And of course, I'm very well treated right now. But that hasn't always been the case. To someone who just woke up this morning and said, I want to do something about my obesity, where do I go for help? And so we have this whole range of folks that are involved in our organization. And I think what is most interesting is the last couple of years, obviously, where we've seen suddenly it used to be hard for us to get obesity in the news and get attention around this condition in the news, and we spent a lot of time trying to do that for the last 2 decades. And then lately, obviously, everyone wants to talk about this. Obviously, a lot of that driven by the innovation we've seen in medicines moving forward to support people in their journey.
Yeah, what a revolution it has been the past few years. GLPs, kind of the second generation of GLPs, have really been a game changer for a lot of patients. But it can be hard to get excited about a treatment when not everyone has access to it. And I know part of your advocacy work is expanding access to effective treatments for the masses. I did not realize, though, the OAC was over 100,000 members at this point. That's some great momentum. Did you have a large increase over the past few years, or has this been more gradual?
I think it's been, it took us about 10 years to build trust in the patient community. And we took on several key issues that sort of said, well, who is this group that's fighting for us? They say they are, but who are they? And then obviously the growth has continued as we moved into the GLP-1 era, right? Kind of thing in these modern obesity medicines. And it is an exciting time, but I do want to pick up on what you said around access because this is still the biggest challenge we face. And I'll be frank here. So OAC is a Florida-based nonprofit organization. We're talking from Tampa, Florida right now, is where I'm located. And for no amount of money can OAC buy health insurance for our employees that covers any obesity care,
Yeah.
right? And that's not an option. And by the way, as an organization, we would pay any amount of money for that, right, kind of thing, because that's what our mission is. But for no amount of money is that available to a small or a small business in the state of Florida or an individual in the state of Florida. And that fight is something that we've been challenging, every day. And it started all those years ago when it was mostly about access to bariatric surgery and behavioral counseling, but in the last few years focused a lot on, because actually in most cases about 80% of people have access to bariatric surgery. Most people at least have some counseling coverage, but the medicine coverage is still probably less than 20 to 25% of Americans have medication coverage in this day and age. And I talked about, with my own experience with all the counseling I've been in and all the medicines I've been on. And it wasn't until the last 6 months when I joined my wife's health plan, and she works for a very large national employer, that any of my own treatment has been covered by insurance. I've always had to pay that out of pocket. And, that's a challenge, right? We have to fix this world where we make sure everyone has access to obesity care.
Yes, I'm completely aligned with that. It's a huge problem. And from my experience and practice, even when someone has coverage, there's no guarantee that the
Mhm.
insurance plan is going to continue that coverage.
Yeah.
Just this past January, we saw a lot of patients get the rug pulled out from under them, doing great on treatment, and then no longer covered or forced to switch treatments that might not be as effective or come with more side effects. So it's a huge, huge problem. And you'll see this play out, right? We see a lot of D2C companies in the
Yep.
space. We see more and more what we call B2B companies, and, all with the intention of trying to improve access to care. But I think there's a wide range of quality between companies that are out there right now. And I know we've had previous conversations about compound GLPs, and it's understandable why patients want to take a chance with them if that's their only affordable treatment option and only access to the medication. But I think where we can really make a difference and where we are starting to see a difference is firmly holding the belief that obesity is a chronic disease and not a lifestyle choice. I think that's a very important distinction. But what's the Obesity Action Coalition stance on that and treating obesity as a chronic disease?
Yeah, so I still remember the first document we wrote as an organization 20 plus years ago. And maybe this was intentional, maybe it was unintentional. I didn't really think about it then, but 20 plus years ago, we referred to obesity as a disease, right? Kind of thing. And so as we move forward, that's always been our underlying belief as an organization. And just to let you know, I mean, it's something that, for example, has freed me a little bit as a patient from some self blame around this issue, right? Most of us have been told our entire lives that we should be able to control this, and it's our fault when a treatment doesn't work for us because we didn't try hard enough. And to be honest with you, that concept of obesity as a disease was freeing for me personally, right? So it took away that blame. Instead of me failing the treatment failed me. And by the way, it made it okay for me to go and ask for more help, right? Instead of actually saying I've got to try to continue to figure this out on my own. And so we spend a lot of time talking about obesity as a chronic disease and really trying to change public attitudes. And I think one of the things that worries me now in the GLP-1 era is a lot of people still see this as a short-term treatment, right? Kind of thing instead of a long-term treatment. And again, I'm not saying you're going to be on the same GLP-1 now that you may be on for the rest of your life, but you're likely going to be in treatment for the rest of your life because this is a chronic disease. And so how do we how do we change the public's attitude around that? And a lot of that I think is based in, kind of old attitudes about diet culture. And you always went on a diet and you did it for 6 months and you did great, and then the diet stopped, and let's be honest with you, probably 6 to 9 months or a year later you've regained all that weight and a little bit back. I mean, that was the cycle I went through many times. And so I think we have to change some of those attitudes in the public. And because I will say, when we survey the public right now, about 80% of people say obesity is a disease, but they don't really act like it is, right? Kind of thing. And there's a lot of self-blame around it still. They still blame themselves, and then they
Yeah.
don't think about treatment beyond this short window, right, kind of thing. And that's something we're going to have to change. This kind of the chronic disease part of it. The chronic part, I think, is the language that we haven't had much success convincing the public about yet.
I agree. And I mean, even medical training, there really isn't much focus around obesity as a chronic disease or what appropriate treatments there are outside of bariatric surgery. And I know with newer medications,
Mhm.
maybe the education has changed since I was in medical school. But I want to dig into a couple things you said there. And you described the weight regain cycle where patients lose weight, then we regain it. And I think that's what really highlights this. This is a disease. This is strong
Yeah.
biology at play. Obesity is a chronic relapsing disease. And yes, I completely agree. Most patients do need to be on long-term treatment after weight loss, our body adapts and wants us to regain
Yeah.
weight. There's differences in hormone signaling that are meant to stimulate weight gain. And it's really hard to stick to a nutritional plan and exercise if thoughts of food, like very intrusive thoughts of food and
Mhm.
cravings are going through your mind constantly. And it's a little condescending when you go into a doctor's office and they tell you to just exercise more and eat less. Like yes, we've all heard the advice, but there's something with our physiology that is making that hard. And I think, like, as simple as that sounds, that's really like just the underlying foundation of how I think of this as a disease and how I wish other providers really thought about obesity. And I think it comes from multiple angles, right? We need the people providing the treatments to really understand it's a disease. We need patients to understand it's a disease and get that freedom that you felt that it's not their fault. It's not a moral issue. It truly is a disease. And kind of in tune with that, you advocate for people first language around
Yep.
obesity. Can you explain to our audience what does that mean and why people should, including healthcare providers, care about the words they use?
Yeah, so language really matters when it comes to obesity. And one of the things that we do in obesity that we don't do as much in other health conditions is we use what we call non-person first language. So I'm going to use it now. And basically, what I'm saying is we should never use the word obese again, right? The word obese, because we wouldn't refer to a patient as cancerous or cancered, right? Kind of thing. And even in
Yeah.
communities where that language was considered acceptable in the past, for example, the diabetes community often referred to their patients as diabetics. That has now changed, right? We are more than our health condition. So my advice to everyone is to say a person lives with obesity, or a person has obesity, or a person has diabetes or lives with diabetes, right? And really move that forward. One of the things is, we just talked about obesity as a chronic disease. And if we want to be treated as a chronic disease, then we have to do all aspects of that. And one of the things that chronic diseases insist is that we use person first language or people first language, depending on which pronunciation you like of it. But the reality is that language matters, and it is hard. It takes practice. I will say, for folks who have used to use the word obese constantly, I will tell you it took me 2 years to work that word out of my vocabulary. And I still remember the last time I used it wrong in a presentation is because I had not practiced the sentence structure. So I was talking about my own development of obesity, and I said becoming obese because I hadn't practiced saying, well, how would I say that, right? Would I say developing obesity, right? Kind of thing. And so I would encourage folks to do that, and just recognize that the stigma and bias around obesity is is arguably the hardest part of living with obesity. In fact, many of us who have obesity as and when we're younger talk about how stigma and bias is actually, and the blame and shame around obesity is the hardest part of living with obesity, despite all the health consequences that come. And of course, we know obesity is progressive, so those health consequences get worse as you age. But we have to battle stigma and bias, and one of the ways to do that is to think about the language that we use and be cautious with the language that we use. And also, for clinicians that are listening today, I would really encourage that you ask your patients about what language they prefer to use when we talk about this topic, and see some clues in that, right? So if they use very negative language to describe themselves, then they've likely internalized some of these attitudes. You're going to have to work with helping them address those internalized attitudes. Oh, and by the way, and then if there's a small group of the population likely not coming in for obesity treatment, but maybe coming in for general health care, who embrace the word fat, right, kind of thing. And that word can be very stigmatizing to some of us, me included. But for a certain part of the population, they've embraced that word, and they're likely part of the fat activism or fat acceptance community. And in those cases, we strongly advise that you consider non-weight centric ways to address their health issues, right? Because most of the time they are opposed to any kind of effort to address their body weight.
Yes, I completely agree. The stories I hear from patients that I've treated that I can take the time to actually listen to them, don't shame them, use people first language. Some of them get tearful because they've had such horrible experiences in the healthcare system. So there's definitely the stigma and bias we have to work to overcome that has such a huge impact on the quality of life for patients living with obesity. And, that's just one of many big systemic, barriers that we need to overcome. And I think the other one we touched on a little bit earlier that I wanna, go into more detail about is barriers to access to treatment. What are some of the biggest systemic barriers you believe people face when they decide it's time I get some help to treat obesity?
Yeah, I think the most common one is simply not having insurance coverage that provides access to the treatments that are there. We in some for some reason in this nation, we require people to earn obesity care, or we just outright deny it. A lot of that I think is based in bias and stigma and misunderstanding of obesity, not considering it a disease. But I will say this is where I spend most of my time and most of my advocacy work, and a lot of our work is focused on trying to improve federal and/or state-run health plans to make sure that they cover obesity care. And for example, Medicare is a big example of that. So if Medicare would cover obesity medicines, it is more likely that private insurers would do so. And just recently, and maybe starting a little bit later this year, probably starting in the July timeline, we're going to see Medicare start covering some obesity medicines for the first time after about what may be almost 2 decades of advocacy around that topic to try to get Medicare to cover obesity medicines. Medicare has long covered bariatric surgery since 2006, and covers some behavioral counseling as long as it's done in your primary care setting, which is not mostly maybe the most realistic setting for it. So we've been working on trying to change that as well. But but medicine coverage has been particularly problematic under Medicare. So we have some cautious optimism. Of course, these things, when they roll out bumpy. We'll see what that looks like under Medicare. What the Trump administration has proposed is Medicare recipients will have access to obesity medicines if they meet certain criteria, which have not yet been published. But that if they do meet those criteria, medicines would be GLP-1 specifically would be available for them for a $50 copay. So we'll have to wait and see how that rolls out. And we actually expect state Medicaid programs to do the same as well, and they're able to access that same lower price. We don't expect the copay in Medicaid to be $50 because that would be beyond most Medicaid recipients' means. But we'll have to wait and see what happens. But a lot of that's going to happen later this year, so we'll have to revisit this conversation maybe in 6 months or 9 months and have a conversation about how that actually rolled out. But I will say the other thing we see is, and you mentioned it earlier, is the constant changing of health benefits right now. And so for many of us, we'll have benefits for 6 months or a year, and then suddenly the benefits are gone, or the benefits now have different criteria. And again, this is the bumpy road of creating care for obesity, and it it's going to continue for a little while longer. But I do have a lot of optimism lately with changing prices, and even some of those announcements were made just in recent days about lowering list prices for these medicines, et cetera. That we're going to see changes, and we're moving towards an era where everyone who needs these medicines will have access to them. I think that happens in the next 2 to 3 years.
Yes, I'm with you, cautiously optimistic, very excited for Medicare and Medicaid coverage. I heard Dr. Oz on a podcast recently, and he mentioned that there might be a $0 copay for Medicaid patients to get GLPs, which if that is actually true, that would be hugely successful in getting people on effective treatments. And, kind of on those lines, we're seeing, I think I alluded to earlier, so there's this direct to consumer market now. We're seeing it with pharmacies. Um, Eli Lilly and Novo Nordisk recently dropped their price for GLPs, going around insurance. And we're starting to see that more and more, kind of taking out the middlemen there and getting patients more direct access without barriers. So, will this lead to more policy changes? Will this create more competition to lower the price? I think all of it is only going to benefit patients and agreed. It's going to be a couple years still, but it's great to see we're moving in the right direction. Is there any policy change that you think would have the biggest impact on the millions of Americans that are living with obesity right now?
Yeah, I really do think it is that Medicare policy that we were talking about before. If this rolls out well and they're doing it as part of a demonstration project, won't go into the details as they're very complicated. It's actually technically two demonstration projects to move this forward, but they're doing a lot of data collection. They're talking about cost effectiveness in this, and what Medicare does, private insurers follow. So if Medicare gets this right, the private insurance industry will likely follow. And it's been interesting times. You mentioned compounding earlier as well, and one of the interesting things that I think has happened is in the absence of some of the price changes which have now happened and compounding filled in, it actually took some of the pressure off employers and others to actually start covering these services. Maybe an unintentional, I mean, yes, it created access for some people, but it didn't create access for everyone. And probably an unintentional consequence of that is that it took some of the pressure off. And so we'll see how this progresses moving forward. But that's another thing that's happened recently is there's been some noise about cracking down on some of the compounding pharmacies that move out there. And again, there's probably good compounders and there's probably bad compounders. One of our challenges at OEC is I can't tell the difference on who's a good compounder and who's a bad compounder because it's not so transparent. And it's been our position for a long time that people should not use compounded products. With that being said, many of our members do. And because that's their only option. And I also understand that from that perspective as well, because if suddenly I didn't have access to my medicine anymore for whatever reason it may be, it's not something I would want to live without anymore, especially people who were on medicine and then suddenly lost coverage. I sort of understand them going to compounding. So this is the struggle we're in right now. But hopefully that era is coming to a close as well as we get better, as you talked about before, better affordability. And honestly, now where the prices are, it's probably an honest conversation that every person who is on compounded products should have with their healthcare professional to say, hey, is it time for me to switch to a branded product? And how close will we be on pricing if we do so? Yeah.
Yes, yes, I think this is a great time to have those conversations with your primary care doctor,
Mhm.
endocrinologist, whoever is helping with the treatment plan. And seeing a lot of small employers, especially, struggle with how to get their employees access to care. I've seen a lot of companies out there that want to help their employees, and they know it's also an attraction to retaining talent, and attracting new talent. People are making job decisions based on healthcare coverage and coverage of GLPs. Where do you see this space going in kind of the B2B market? Do you find that these programs that are popping up that are targeting employers to help them find affordable solutions for their employees is making a difference in expanding access to care for patients?
I think at the large employers, I think the answer is yes, depending on which provider they actually pick to do so. And again, there's different attitudes among some of those B2B providers. Some are marketing themselves as, hey, we're going to save you money and get people off of GLP-1s, which sort of makes me nervous. I mean, look, there are people who probably should not be on these medicines taking them, but there's also the vast majority probably are taking them appropriately. So that kind of narrative. But then others are, it's like, hey, we're going to manage and make sure your people stay on the medicines, use them as effectively as possible. And those services obviously will be good for the field in the long run. I think my one underlying worry is, if we really are going to treat obesity as a disease and a chronic disease and all the health complications the way it's, some of the programs that seem to carve out just the weight loss side, just the medicine side, make me a little bit nervous because we're not talking about the overall health of the person, right? Kind of thing. So you make me go to a provider X for my weight loss, but then my primary care is expected to take care of my knee osteoarthritis, my blood pressure, and all those other things. Like I think we miss an opportunity of kind of the holistic care that people need moving forward. So that'll be the next, I think, the next frontier when it comes to these programs is like, how do we link how do we make sure that there's good linkage between primary care and those programs? And again, a couple of those B2B providers are starting to do that right now. They're starting to say, hey, we for you to participate, we are directly are interacting with your primary care provider, right? Kind of thing to make sure that we move forward with this. But knowing that it's been hard, right? And again, I innovation comes in spurts, and one of the things that I'll say is that the innovation in medicines has far exceeded the system to care for people as moving forward right now. And so we're playing catch up in many of these cases. And I think it's important that we figure that out, right? What does good quality of care look like? What does the good wraparound care that goes along with these medicines look like? I think that's the next frontier. Like we need to figure that out. We need to publish guidelines on that. We might just publish a standard of care or whatever it may be. But right now, it's a little bit all over the place, and that makes, again, sort of like the compounders, makes me nervous at times.
Oh, yes, I completely agree. And when I hear companies boasting about how many people they get off of GLPs, it makes me very nervous. Completely ignoring the rebound weight gain that we see when people come off of the medications that is shown in the clinical trials. And a lot of those studies too are short term. See how that patient's doing 2 or 3 years off of
Yeah,
the medication and,
right.
not just 12 weeks off of the medication. But I want to call out something you said that I thought was very accurate, and it's highlighting this problem we have with the integration of care. There's a lot of point solutions out there where they just manage obesity. There is no interaction with the rest of the patient's care team, their endocrinologist, their primary care doctor, whoever else it might be. And we know that leads to more, medical mistakes, and it's just such fragmented care. It doesn't work. So really finding a solution that does have the integration in the healthcare system, I think is really important just for the best outcomes and getting the patient, to the healthiest version of themselves that they can be. And with that, I'm going to kind of pivot a little bit because there is this sense that you hear about in social media that, it's either diet and exercise or it's medication. There seems to be people out there that think it has to be one or the other. And most patients I have found would agree with me when I say it's not one or the other, it's both. Both are needed. This is a very complex disease and it takes a multi-pronged approach. There isn't just one silver bullet in terms of solutions. But I would love to get your take on this and where you see the role of not just exercise and diet that we all hear about, but how stress and relationships and sleep all impact weight and outcomes as well.
Yeah, so I'm really a believer in the full toolbox, right? So we need all the resources available, and so we need to meet people where they are. And the reality is that some of us may need diet and exercise advice. But look, most of us probably could eat a little better and move a little more, right? Kind of thing. And by the way, that advice should be provided to all of your patients, not just your patients who live with obesity. Let's be fair about that. And then we need access to medicines and surgery too, because we need to meet where people are at those times. But I will say that I think in our culture and our obsession with food, diet, and exercise, as we've missed some of the underlying factors about why people eat and or why people don't eat, or why people exercise or why people don't exercise, and that is, these sleep and stress issues and things along those lines. Like I really wish we spent as much time talking about sleep and stress as we would talking about diet and exercise as part of this, right? And again, this is something that I think about in the GLP-1 era, and then previously in the surgery era. And again, we're still doing surgery to this day, and it's still a great resource for people that we need to think about in the long term, right? Kind of thing. We need all of those tools to do that, and we need to provide the long term support of people on that journey. So the journey may look very different in the 6 months or a year that you're first initiating your treatment, right? Kind of thing, versus hey, someone like me who's been on treatment now for years, what does that look like, and what are the tools and skills that we need to address? And I think oftentimes I see this obsession with like the first year, and you see this obsession with how much weight loss you get and all that other stuff, and less talk about the maintenance part of that. And again, this is back to our original concept about obesity as a chronic disease, right? We're missing that. And I think those skills that we can teach people, they come across very different. I will tell you, I've always been taught, I've been in all these behavioral programs, like to eat less and to move more, right? But it was interestingly, it wasn't until I was, on my latest generation of medicines that I was able to actually follow that advice and use that advice, right? Despite wanting to. And actually, Kevin Hall proved this, right? When he did some of his research, right? He proved that patients are trying just as hard, right? Kind of thing. It's just not that the outcomes aren't coming, right? Kind of thing. And it was interesting that it's a medicine that did that. And then maybe one final comment on medicines, just because as part of my work, we've also been trying to change the food and activity systems in our nation for the last 20 years. And it is really remarkable to me that it's going to be a medicine that actually motivates the system to change, right? Kind of thing. I was there when Mrs.
Yes.
Obama launched the Let's Move campaign, and we tried to change the food system. And we made some small progress at that time, but nothing major. And guess what? Now, food companies want to have these conversations with us now. Why do they want to have it now? Because the GLP-1s are changing consumer behavior and what really drives their bottom line. And so, therefore, now they realize they're going to have to adjust to do that. And so, it's just been an interesting part of the world we live in where, for years, the food companies didn't want to talk to us. Now, all of them want to engage with us because they want to better understand how these new treatments are actually affecting consumer behavior.
Right. You get their attention when their bottom line starts changing. Then they want to join the conversation. And I think what you're talking about too about stress and sleep, as sleep especially, I think is underrated, not just with weight loss, but in overall health and health span and how you feel day to day. This is just foundational information. I feel everyone should get to improve their own health and improve their health span as they age. So, I just love the work that you are doing and bringing attention to all of this. And coming up next week is, well, I should say next week is the time we are recording this. But the first week in March is Obesity Care Week. What are you hoping Obesity Care Week accomplishes this year, and how can people get involved?
Yeah, so Obesity Care Week, you can find more at obesitycareweek.org, right? Kind of thing to find more about what you can do to get involved. But really, we want people to commit to care. And now, when I say to care, I mean to care about the topic of obesity, to seek care if you need it, whatever it may be. And that really is the goal, is just to get the word out and to actually talk about this and from a greater perspective. And we have 150 organizations who get involved in supporting Obesity Care Week. And that really shows some of the change we've seen in society because we've been doing this for quite a while now. And I don't necessarily know that we had 150 organizations involved before, right? People are starting to realize that we have to address this topic. We have to take obesity seriously and we have to commit to that care. So I would encourage everyone to check out Obesity Care Week's website, learn how you can get involved. There are specific policy actions you can take, there are education actions you can take, and different ways you can get involved in that site. And I'd encourage everyone to check it out.
Excellent. And, what would your message be to someone who has been dismissed or shamed by the healthcare system and has kind of given up on finding help?
Yeah, I would tell a story, and that's my own personal experience. So recently, I had to pick a new primary care provider because mine went concierge, right? And so I needed to find a new one who would be covered by my insurance. And of course, I did some research, and but I will say that my experience going into that doctor's office looked very different than in my experience previously. I remember having to be weighed in a public space. I remember being my finger wagged at me by my doctor in the past. And what happened this time is I walked in an office and I saw an office. I don't need a larger chair anymore, but I see chairs that were larger if I needed one, right? Kind of thing. I was actually taken in the back and weighed in a private location. No comment made about my body weight, right? Kind of thing. No even saying it out loud. And then I went in to talk to my new PCP, and she treated me with a level of compassion and empathy. I was super nervous because I thought, well, she's going to dismiss this fact that I've sought so much care for my obesity, and I was in the middle of care for it. And what, she embraced it completely. In fact, embraced it so much that she took over my care, right, kind of thing, and actually is the one who I mentioned that my wife's insurance started. Because she's the one who convinced me to go on my wife's insurance plan and start actually covering my medicine, kind of thing. And it was just a completely different experience. I will tell folks, if you've had a negative experience now, seek a new provider. Look for someone who has experience in obesity, and my bet is you're going to have a different experience today than you said had 5 or 10 years ago. there are good providers out there, and providers that really can change your life to make sure that you reach the best health you can ever reach.
Absolutely. And I will kind of do a plug here for looking for doctors who are trained and board certified in obesity medicine. But they put in the extra work to really understand the disease and the treatments, and are often very empathetic to patients. And every year we're getting more and more obesity certified doctors. So I think that would be a good thing to look into
Yeah,
when
look for
trying.
that ABOM after
Yes,
their names,
ABON,
American
triple
Board of
net.
Obesity Medicine. And honestly, I said when I did my research, that's what I did too. I actually waited 7 months to see my primary care provider to get a new patient appointment, just because I wanted someone with that ABOM designation, and it made all the difference in my care. It's really renewed my confidence in the healthcare system and under her support. So yeah.
Oh, that is great to hear. With healthcare in the state that it is, those little wins can go a
Yeah.
long way. And Joe, I just want to thank you for your time today. It has been such a pleasure talking to you and hearing more about the work that you're doing, and everything that you're involved in. And where can listeners connect with OAC and get resources or get involved with your
Yeah.
organization?
Yeah, so it's super easy. It's obesityaction.org. And membership in OEC is free. So you can join as a patient or a healthcare professional to access our resources. And you name the topic, we've likely covered it around obesity over our last 20 years to move forward. And if you're interested in advocacy as well, we have all kinds of teams where you can get involved to support our advocacy efforts at the state level or at the federal level. And if you're struggling with your own insurance coverage and trying to fight for coverage, reach out to us because we have resources to help you. Maybe have a different kind of conversation with your employer. We no promises, obviously, because it's a tough lift in some, especially with some small businesses. But we can give you the letters and the materials you need to try to fight for better coverage at your employer.
That is hugely helpful. Because sometimes it is a battle. Sometimes you do have to talk to your employer and HR, or even get your doctor on board.
Yeah.
So it's really great patients have a trusted resource they can go to for help with this. Well, thank you again, Joe. It has been a pleasure, and I look forward to seeing you at some upcoming conferences this year.
Thanks again for including me.
Take care.